Hello, good morning. Hello, hello, good morning.
Good morning, sir.
Yeah, good morning, Mr. Alabi. Hello, do you have another person in the class, please?
We're about 10 now, sir.
Good morning, sir.
Yeah,
Good morning.
okay, good morning. Good morning.
Yes, sir.
Good morning. Thanks for joining the class. Maybe we should just start while we wait for the slide to load. Because I'm having issue loading the slide. The platform is asking for a type of file, but I have a PowerPoint file. So it's asking for PDF. So, but that notwithstanding, so that we don't waste time, let's just start moving. And when Fatima sorts that out, she will help us to display it. So, can we continue?
Yes, sir.
Okay, so we are going to talk about types of blood substitute, and preservation. So, like I said initially, we want to see how we can make this class, to finish on or before end of this month. And the way we are going, the pace at which we are going, I think we are going to meet up. So after this class, after today's class, tomorrow's class will be the last class for the BGS 505, and that will be it. Then we'll go and face another thing entirely. So let's just browse through. There is nothing there. There's nothing there. It's nothing you have not heard of. So the introduction, we're talking about types of blood this morning. And when they talk about types of blood, we are not talking about ABO blood grouping or what have you. We're talking about the type of blood that can be transfused. In what form can we transfuse a whole blood? As we all know, whole blood contains both plasma and cellular components, and the cellular components can be separated into different things which can be used therapeutically. So as med lab scientists that we are, because we are very key to modern medicine, it is very essential for us to understand the types of blood substitute, and how they can be properly preserved, which is what this lecture is all based on. Now, when we talk about types of blood, let's start from the whole blood itself. Whole blood like we said, whole blood. It contains everything, both the plasma and all other cellular components. So they are yet to be separated. The blood is collected by donor and kept inside a container. Container that we're talking about this time is blood bags, as we all know. And we know that blood bag contains anticoagulant and other preservatives that make the blood to be viable for a particular period of time, depending on the anticoagulant used. So whole blood contains majorly, red blood cell, contains red blood cell, contains plasma, platelets, and coagulation factor. So, and they are contained in their original proportion anyway. So moving on, what are the uses of whole blood? It is used when it is desired to return oxygen capacity of the blood, and also to restore blood volume. When there's blood loss, apart from the fact that red blood cells are lost, which leads to anemia, there is what they call volumic shock. When there's a massive blood loss, when someone is bleeding profusely. So, so there is massive loss of blood, and when blood is lost, apart from losing the red cell, which carries the oxygen, the fluid cell, which is the plasma, is also lost. So that could cause a big complication. And whole blood It's used during massive hemorrhage, like I said. It's used for neonatal. I mean, when neonates have jaundice and the blood needed to be removed and replaced with another unit. So whole blood is used in that condition. It's also used in surgical procedure and in traumatic conditions. How do we store it? The most popular is the bag containing CPDA1 as anticoagulant, and it is stored at 2 to 6 degrees C. And it can be stored like that for 35 days. We know there are other anticoagulants and preservatives that can store either lesser or longer than 35 days. I wouldn't bother ourselves with that, but I know we know that. What is the disadvantage of giving whole blood? One, it can cause circulatory overload, especially for um, people with heart disease and kidney diseases. Also, the platelet and clotting factor are lost within 24 hours, and there's a high risk of transfusion reaction and infection compared with when the blood has been separated to its components. Another type of blood that can be transfused is called packed cell. Packed cell is prepared when you remove the plasma or the fluid part of the rest of the whole blood. You get packed cell. And when is that used? It is used when you really need to restore oxygen carrying capacity. For instance, in sickle cell anemia, we all know that the problem with the condition is the lysis of red blood cells, which leads to having lesser oxygen carrying capacity in those patients. So it is preferable to transfuse packed cell in such condition. And it can also be used during trauma, surgery, and severe anemia, like malaria parasitic infection. I mean, malaria parasites, when there's malaria parasite infection, which leads to destruction of red blood cells, we don't need to transfuse whole blood because the patient is not, has enough volume. It's not lacking any plasma. What the patient needs is the cellular component, which is the red cell. So, partially packed cell is the best or the ideal product to be transfused. How do we preserve partially packed cell? We can preserve it using CPDA as well, but where you needed to, where you need to make it to be there for a longer time. When you need to store it for a longer time, you can use additive like SAGM to preserve it. And that one will make it stay for up to 42 days at 2 to 6 degrees C. Disadvantages of using partially packed cell is that the risk of circulatory overload is high. It's very high because you are putting in a highly concentrated product into the system. And also plasma-related reactions are, sorry. Advantage is that the risk of circulatory overload is low. It reduces the risk of circulatory overload because you are not putting the whole blood. Plasma is not included in what is being transfused. So you are putting just what the patient needs. So it maintains the volume, the required volume in the system. And because plasma has been removed, so all transfusion reaction that may be caused by plasma is also eliminated when partially packed red cells are used. The disadvantage is that there is no clotting factor because plasma has been removed, no clotting factor, no platelets, and the viscosity of the patient might be increased in the sense that you are putting a very thick product into the system. So if the calculation is not properly made, it could lead to viscosity of blood, which can cause other complications. Moving on, so let's talk about platelet concentrate as another way of transfusing blood because platelet is also one of the components of whole blood. So how do we prepare that? We prepare that by, from platelet-rich plasma or from buffy coat, let's put it that way. and it contains viable platelets in suspension of plasma. That is, you have to put a little plasma so that when they are transfusing, there will be something for the plasma to flow through. So it is used during thrombocytopenia or when there's platelet disorder, especially during active bleeding or before before invasive procedures. How do we store it? We store at room temperature, which is 20 to 24 degrees C, with continuous agitation. If there is no agitation, platelets are bound to clump or aggregate, and there will be activation when they aggregate and the platelet is gone, which means if you are just transfusing, you are transfusing just the plasma that the platelet is suspended in. And the shelf life is between 5 to 7 days. Advantages of platelet concentrate is that it contains bleeding quickly, especially if the bleeding is caused by low platelet count. Disadvantage is that risk of bacterial contamination is very high because it's not stored in fridge. It's stored at room temperature. So bacteria and other microbes can quickly grow in that unit. Then it has a very short life. Imagine 5 to 7 days, and that will be it. Then another one that we're going to talk about this morning is the fresh frozen plasma. It's another way of transfusing blood. And this one is gotten from blood that are freshly donated. I mean, blood that is not older than 6 hours. That is when you extract the plasma from. Now, it contains almost all the coagulation factors. So it is used for coagulation disorder, and it is used for liver disorders because liver produces factor 7, and if there's problem with liver, there will be no factor 7. And since FFP contains almost all the coagulating factors, in fact, it's rich in factor 7. So it is ideal product to transfuse if there's problem with the liver. Now, it can also be used when there's an overdose of warfarin to reverse the situation. They give FFP. So FFP is just the same way. It's going to replace the factor 7 back to the system. How do we store it? We store it at any temperature below minus 18 degrees C, and it can be stored up to 1 year at that condition. The advantage of FFP is that it provides, like I said, all plasma protein and clotting factors. Now, the disadvantage is that there's risk of volume overload and transfusion reaction. And again, you have to wait for it to thaw. It cannot be transfused during emergency because you have to wait for it to thaw before you can use it. So let's move on to another one. Another one is cryoprecipitate, also called cryo for short. And basically that is produced from FFP. And it is rich in fibrinogen, factor 8, factor 13, and VW, von Willebrand factor. Now, how do we prepare that? The FFP has to be thawed inside a fridge and then spun to get a precipitate from the FFP. So, and the precipitate is rich in fibrinogen and all other factors that I've mentioned above. It is used in low fibrinogen, that is hypofibrinogenemia, when there's low fibrinogen, which could be a cause for bleeding, disorder. It can be used also in hemophilia, and when your patient is being treated for von Willebrand disease. So that too can be stored as minus 18 degrees C or lower for up to 1 year. Advantage is that it contains concentrated form of fibrinogen and all other factors, which means if the patient is already having enough load within his circulatory system, you just need, and the patient needs coagulation factor, cryoprecipitate is the best option because it is very small. There will be no overloading when you use cryoprecipitate. But when you continue using FFP, even when the patient has already gotten enough within the system, overloading is imminent. The disadvantage of this is that it carries risk of infection and reaction, and limited volume of place that this very small volume is available for transfusion. You can't see it in a very big form. That means you have to collect bags, little, maybe 2-3 bags before enough can be given to a patient. Let's move on. Then another form of blood that can be used for patients is called plasma derivatives. What are plasma derivatives? These are manufactured from pooled human plasma through fractionation. Fractionation is simply the breaking down, the separation of the component of plasma. We're talking about component of blood all along, but this time around, we are talking about component of plasma. Component of plasma, majorly the globulin, are very useful, especially when in immunodeficient patients. So, their uses is, because they contain specific protein, so they are used for specific protein deficiency. They're also used in shock management and immune therapy. Like I said, they are very useful in immunodeficient patients or immunosuppressed patients. So that is for plasma derivatives. How do we store them? They are usually stored at 2 to 8 degrees centigrade. And because they are highly purified and pathogen free, it makes them to be very advantageous for use. Their disadvantage is like they are very expensive to make, and they require specialized equipment and production line. They may also cause allergic reaction anyway because they are made from immunoglobulin, which can cause reaction if they are not compatible with the system in which they are put. Now, that is the end of the other types of blood, other forms of, or how will I put it, other ways of transfusing blood apart from using whole blood. So we are going to talk about next is blood substitutes and how they are preserved. Like I told you, we are talking about transfusion science, which is how we can manage low blood within the system of a patient during shortage or when there's a massive need. So there are some times that we have a situation at hand where we cannot use blood or blood is not even available at that condition. Just give me a moment. Sorry, I had a call from the class rep, so that's why that's the reason for the instruction.
Sorry, sir. I said you can share the slide now. Check the WhatsApp. You can share the slide now, sir.
Okay.
It has been converted. It has been converted.
Okay. Thank you. Please just give me a moment. Let me see how we can share the slide. I'm going to go out and come back later. Hello. Hello, can you
Hello,
hear
sir.
me?
We can see you. Yes, sir. We can hear you, and the slide is displaying, sir. We can see the slide, sir.
Okay. Okay. Thank you. Thank you.
No
So
problem.
we are actually discussing blood substitute and their preservation now. So, like I said, there are some conditions where blood cannot be transfused, or there are some situations where blood cannot be transfused. For instance, during wartime, in military, in war zones, there may not be enough time for us to start looking for donor and doing compatibility tests. And if there is need for blood to be replaced, there should be something that should be given to the victim for them to continue their life. Apart from that, we have some religious sects. For instance, the Jehovah's Witness, they don't accept blood transfusion. But despite that, we can't leave them and let them die when they're in crisis or when they need blood. So that is why we need to find a way around it by, doing blood substitute. And, apart from producing the substitute, we have to find a way to preserve them. So blood substitute actually fall into two categories. There are some that bind oxygen, and the other one, they move oxygen from the solution. That is, they cannot bind, they cannot do chemical reaction like the first type. All they can do is to move oxygen that is available in a solution. Now, let's go to the oxygen carrying substitute. This is known as, in short, HBOCS. They are made from synthetic hemoglobin. We all know that hemoglobin lives in the red cells. They are not outside. But the moment they go outside the red cells and they are not well taken care of, they become dangerous. They can be poisonous and cause complications in organ. So what the scientists do, or the people that started this mission did, is that they now synthesize hemoglobin by extracting it from the red cells, and they now, how will I put it, they manipulate it in such a way that it can be available for a long time within the system. It can bind oxygen and it will not be poisonous to the system. Now, how do they work? The way they work is, like I said, they bind oxygen to hemoglobin outside red cells and release it into tissue. So this substance called HBOC have ability to take oxygen, bind it, bind with it, and go and deliver it just like the red cell. The only difference is that these are synthetic, they are biotechnologically derived hemoglobin. Example of them, of such is Hemopure, Polyheme, Hem Assist. So where are they useful? They are useful in temporary replacement during severe anemia or during massive blood loss. When cross-matching is not possible, like I said, during war zone or during emergency services. So they are useful in those situations. Now, the advantage is that you don't need to cross-match and they don't carry any pathogen. Of course, they are sterile and they don't carry any pathogen. They are stable and have a long shelf life at room temperature for that matter. You don't need fridge, you don't need any coolant to store them. They are good to go at room temperature. The disadvantage they have is that they can cause vasoconstriction and oxidative stress. They have short plasma cells. What that means is that once they are introduced in the plasma, they don't stay long before they are excreted or they are washed off in the plasma. So that is one of the disadvantages. They are still under clinical evaluation. It is not fully accepted in the medical world. So they can be stored for up to 2 years at room temperature, depending on the formulation. The brand, that is what I mean by the formulation. The another type of oxygen binding blood substitute is called PFC, which is perfluorocarbon emulsion. So this one is made from fluorine and carbon, and they have affinity for hemoglobin. So it's just the same way as the previous one. They bind hemoglobin and take it to tissue where they are really needed. So Their uses is just the same thing: organ preservation, ischemic condition, surgery, and trauma. And the advantages is that they are chemically stable, they are not infectious, they can be used for all blood groups, that you don't need to cross match. They have a long shelf life. Disadvantage is that they require high oxygen concentration. That is, the victim has to have the ability to retain a lot of oxygen within them for this substitute to function. They have limited oxygen carrying capacity, causes flu-like symptoms. Those are the side effects. They can also be kept at 2 to 8 degrees C, and they have share life up to 2 years. So that is perfluocarbon. So I said there are 2 types of substitute. We have one that have the ability to bind hemoglobin. The second type don't bind hemoglobin, but they move hemoglobin in solution to where they are needed. They are called, mixing it up. This one is now a plasma volume expander. That is, though they don't bind hemoglobin, but they have ability to expand. That's another type of blood substitute. They have ability to expand the plasma. Like I told you earlier, that during hemorrhage, cells are lost, then fluid also are lost. When too much fluid are lost, it can cause volumic shock. So you need something to replace the fluid, and that comes in form of plasma. But in case you can, in the situation where we cannot transfuse blood, we need something to expand the little water within the system, and that is where the plasma volume expander comes in. They are used in shock, in burns, or severe dehydration to maintain tissue perfusion. Examples are the colloids and crystalloids. Now, let's talk about crystalloids. Example of crystalloid is normal saline, ringer lactate, 5% dextrose. So the mechanism is that they rapidly take fluid from the extracellular and bring them back into the bloodstream. That is how they work. It's like hemolysis. When the salt concentration is increased in the bloodstream, it tends to bring water out from the tissue and migrate those water into blood system so that there will be enough fluid within the circulatory system. Advantage is that they are inexpensive, they are readily available, they have no risk of infection or immune reaction, of course. Disadvantage is that short intravascular duration causes hemodilution or electrolyte imbalance. Then how can they be stored? Of course, at room temperature, and they should be stored in sealed sterile containers. So moving on, let's do colloids. Example of that is dextran, gelatin, hydromethyl starch, and albumin. The mechanism of which this one works is that they contain large molecules that retain fluid within the circulation by maintaining oncotic pressure. Oncotic pressure actually is a form of osmosis pressure, where water moves from high concentration to low concentration. But in this case, what is being used as membrane is the protein. For instance, the albumin is used as the membrane in this case. So what this one does is that it causes water from other part of the body to enter into the bloodstream so that there will be enough fluid within the circulatory system. The disadvantage is that, and let's talk about advantages first. Longer lasting plasma expansion, unlike normal saline and the rest that we talked earlier, which are basically water. This one have a longer plasma extraction. Smaller effusion volume is required, and the disadvantage is that because of their mass, because they are large stuff, so they can interfere with blood grouping cross matching. There's risk for anaphylaxis and coagulation disturbance when they are being used. They are stored at room temp at 2 to 25 degrees C, and they are stable for 3 years, depending on the type of product that is used. So that is that. Now that we know different types of blood substitute, let's go to preservation of blood and its components. For whole blood and red blood cells, so we're talking about the temperature should be like 2 to 6 degrees C, platelets at 20 to 24 room temperature with continuous agitation. Plasma and cryo can be at a very lower temperature, up to from minus 18 degrees C and lower. And they can be stored for 12 months anyway. Anticoagulants that are used in preserving all these things, all the blood and its components, majorly we can use CPD, which is citrate phosphate dextrose. And that one will store blood for 21 days. CPDA will store for 35 days. And if there's an additive in the system, for instance, if SAG-M is used, it can prolong the RBC because it's going to help in the RBC permeability and also improve ATP generation. And that makes the blood to stay for up to 42 days. Sterility and sealing rather. Use closed collection system to prevent contamination. See, once the thing is open, it should not be more than 6 hours before. Once the bag is open, max is 6 hours, it should be discarded. If not, there is risk of bacterial infection. Cryopreservation, that is, we can preserve them in liquid nitrogen, but you cannot just preserve them like that nakedly. They have to be protected. And in this case, glycerol is used at 40% or 20%, depending on the concentration at which you want to keep them. And they can be kept at minus 80 degrees in liquid nitrogen. They can stay there for like 10 years. The last slide is just a little quiz which you can practice after reading through this slide. So, hello?
Right.
Yeah. Please, I want to leave now so that I can load the second slide and we can do
All right,
the
sir.
remaining lecture. Thank you.
You're welcome, sir.
Hello? Hello?
Yes, sir. We are hearing you
Okay,
and the slide is being shared, sir.
okay, okay. Now we're going to talk about preparation of blood product, and that is not really much. We're just going to browse, through it, since it's not something that is alien to us. Now, the definition, let's just talk briefly on define little terms concerning this topic. Talk about whole blood. Whole blood, like we all know, is made up of cellular components and plasma. A unit of whole blood is about 450 ml, and in that 450 ml, you have 250 to 300 ml of RBC, 180 ml of plasma, and little amount of platelet. Now, when we talk about blood products, like as we all know, is any constituent of blood that is prepared from the whole blood. Talk about packed cell, platelet, concentrate, FFP, stuff like that. Then again, we have what we call plasma derivatives. They are human plasma protein prepared by fractionation under pharmaceutical manufacturing regulation. Example is the albumin. Then key equipment that we need. What are the important things that we need in production of blood component? We talk about, of course, a refrigerated centrifuge, which we all know as cold centrifuge. We talk about plasma extractor. We talk about tube sealer and snap freezer. Snap freezer can also be called blast freezer. These are freezer that when you just put any material, they freeze immediately. So moving on, what are the methods? We have two methods of producing components. You can use the whole blood component method, in which you collect whole blood and you start separating them into fraction. And you can use apheresis. Apheresis is where you just collect what you need from the donor and you return back all those that you don't need. Those are the two methods involved blood production. Now, let's go to blood component production. Let's go to preparation of blood components. Let's talk about packed cell. How do we produce packed cell? The whole blood will be spun softly in a cold centrifuge anyway at a particular temperature, and then you will separate whole blood is not spun. You just collect the blood and you use it like that. But when you are talking about partially packed cell, that's when you spin it. After spinning it softly, you remove the plasma from that, and then you keep the cellular component, which is the partially packed cell. It can be stored at 2 to 6 degrees C for 21 days, depending on the preservative in the bag in which you put it. And if you want it to stay longer, you can add other things like SGAM. SGAM, I've forgotten the full name, but I know there's mannitol in it, which preserve the cell wall and also prolong the life of red blood cell. Then you can do leukocyte reduction if you want to improve it. Maybe you want to give it to immunocompromised patients. Then we have to remove a lot of leukocytes that can cause transition reaction. And also for immunocompromised patients, red cell can be washed using normal saline. Of course, you wash just like washing our regular red cells, but it has to be done under a septic condition. And also you can irradiate it. All these are used for immunocompromised individuals. Now, let's go to the platelet concentrate. To prepare a platelet concentrate, you have to spin the blood lightly first to collect platelet-rich plasma. Then you now spin the platelet-rich plasma again. You spin that hardly, very hard spinning. And when you do that, it's going to separate the platelets at the bottom and then free the plasma from platelets, and you have plasma-free platelet-free plasma rather, and then It can be stored at 20 to 24 degrees C, like we said earlier, under agitation. And the lifespan is 5 to 7 days. Playlist can also prepare by apheresis. And let's go to another product, which is the FFP, fresh protein plasma. Now, fresh protein plasma, you just spin the whole blood softly at 4 degrees C. And you separate the plasma into a separate bag, and you freeze immediately at 30 degrees C, and it can stay like that for 1 year. It is rich in all factors, like we said earlier. And before you use it, it has to be thawed. That is FFP. The other one, we have so many, but let's just talk about the 4. I talked about 4 actually. Those are the 4 most important that I picked. So preparation of cryo. Like I said, cryo will be prepared. It's going to be prepared from FFP by thawing the cryo at 1 to 6 degrees C. Then you spin to produce a precipitate. That precipitate, which is a supernatant plasma after spinning, is the cryo we are talking about, and it contains a lot of clotting factor. That precipitate is dissolved in little plasma, and it can be stored at minus 18 degrees C or lower, and it can stay like that for 1 year. Sorry. That's not the end of the slide, but that's how far the conversion made to me can go. Yeah. Okay. Can you hear me? Hello?
Hello, sir. I can
Yes,
hear you. You said
we
that
can hear you,
Yeah.
sir.
maybe the compression caused it to be like that, sir.
Yeah. I still have 1 or 2 slides. So if you can hear me, let me just run to my document and let's have the remaining slide. Just hang on. I'm not going to log out. Just hang on. Okay. Yeah. Anyway, I think the thing is it is distorted. That is why the conversion stopped there. Now, we've talked about all types of blood products. And the next thing I actually wanted to do is to just give you few quiz rather, which you can practice with. And although you are supposed to know the indication. Hello? Is somebody talking to me? Okay. So I said because of distortion, that's why the conversion stopped where we are. And the remaining slide is talking about, actually it should be about quiz and how this product can be, the indication for the product. When are they used? For instance, we know FFP can be used for warfarin overdose. It can be used for clotting factor deficiencies and stuff like that. That is the indication. Failure concentrate can be used for thrombocytopenia and when we have platelet disorders. So failure concentrate can be used in that condition. These are the basic things that are there. And then the next is the quiz, which we can practice after studying the slides. I will send the full slide actually to the class rep, and we can get that for ourselves too. So that will be the end of the class for today. Hopefully, we'll continue tomorrow and we bring the course I think it's 5:05. So a close, as we promise. I mean, Dr. Akpan and I promise we're going to move very fast so that we can cover as much as possible latest by end of November. Let us settle all the lectures. So I don't know if we have questions or concerns you want to raise. Is anybody in class?
Yes, sir.
Yes, sir. We're in class, sir. I don't have
Okay.
any question.
Okay, so thank you very much. Now,
No question,
after
sir.
tomorrow, okay, after tomorrow's class, I'm going to send a few questions to the class rep so that we can use that as our CA. So I will tell her where we are going to submit it, and that will be for our CA. So that's all for today. I wish everybody a peaceful
Sorry, sir, I
weekend.
have a question. Sorry, please, sir. My
Is
phone
okay?
was hanging.
Oh, I see. No problem. I'm
Okay.
with you.
Yes, I could not get, when you were explaining about the pack cell, talking about the storage temperature. I
Okay.
think you mentioned that I don't know where I was confused, whether it was, I had 24 hours. I don't know, I couldn't really get that particular, if you want to store red blood, pack cells,
That's
for,
okay.
for like how long? And if you want to store
Okay.
it longer, what can we do?
Okay. For Paxel, we store at 2 to 6 degrees C. And depending on the additives inside the bag in which you collect the blood originally,
Okay,
it can be stored for 21 days. That is
okay,
if you use CPD. But when you use CPD A1, it can go longer for 35
okay.
days.
Thank you, sir.
But
That's
if you want it
CPD.
to be stored for 45 days, that means you have
Okay,
to add SAG-M. It will store for
okay,
42 days. But if
okay,
you
sir.
still want to store it even further, for instance, if you have rare blood group and you want to
Okay,
store further, you can preserve it in liquid nitrogen, where you are going to use
okay,
glass zero as a
okay.
protective covering for the
It
cell.
serves. Thank you so
Yeah,
much, sir.
those are
Thank
the
you, sir.
ways to store Paxil.
Thank you, sir. God bless you, sir.
You're welcome. So, like I said, that will be it for today's class. I hope to see everybody tomorrow by God's grace, and I wish all of us a peaceful weekend. Ó ń lọ dáadáa náà ni.